So, anti-diabetic drug, insulin and oral hypoglycemic drug. What is diabetes mellitus? Diabetes mellitus is a group of metabolic disease characterized by hyperglycemia, glycosuria, hyperlipidemia, negative nitrogen balance, and sometimes ketonemia. Diabetes mellitus is resulting from defects in insulin production, insulin reaction, or both. The effect of chronic hyperglycemia of diabetes mellitus is associated with long-term damage, dysfunction, and failure of various organs, especially the eye, kidney, nerves, heart, and blood vessels. What is hyperglycemia? When fasting plasma glucose level more than 126 milligram per deciliter and or PP plasma glucose, that is 2 hours after 75 gram glucose, is more than 200 milligram per deciliter, and HbA1c level is more than 6.5%. Types of diabetes mellitus. Two major types of diabetes mellitus. Type 1 diabetes mellitus, which is known as insulin dependent diabetes mellitus or juvenile onset diabetes mellitus. Insulin is required for treatment. Type 2 diabetes mellitus, non-insulin dependent diabetes mellitus or maturity onset diabetes mellitus, can be treated with dietary and lifestyle modification with or without oral hypoglycemic agent. Other types of diabetes mellitus, gestational diabetes, when increased glucose level first time seen during pregnancy. LADA, latent autoimmune diabetes in adult. MODI, maturity onset diabetes of youth. Secondary diabetes mellitus. Secondary causes of diabetes mellitus include acromegaly, Cushing syndrome, thyrotoxicosis, pheochromocytoma, chronic pancreatitis, pancreatic cancer, drug-induced hyperglycemia. Type 2 diabetes mellitus. Type 2 diabetes mellitus are previously called non-insulin dependent diabetes mellitus or adult onset diabetes. Type 2 diabetes may account for 90 to type 1 diabetes mellitus. Type 1 diabetes mellitus previously called insulin dependent diabetes mellitus or juvenile onset diabetes mellitus. Type 1 diabetes develop when the body immune system destroys pancreatic beta cell, the only cell in the body that make the hormone insulin that regulate blood glucose. This form of diabetes usually strikes children and young adults, although disease onset can occur at any age. Type 1 diabetes may account for 5 to 10% of all diagnosed cases of diabetes. Risk factor for type 1 diabetes may include autoimmune, genetic, and environmental factors. In all type 1 diabetes mellitus cases, circulating insulin levels are low or very low, and patients are more prone to ketosis. For people with type 1 diabetes, daily insulin injections are essential to maintain health. Now, type 2 diabetes mellitus was previously called non-insulin dependent diabetes mellitus or adult onset diabetes. Type 2 diabetes may account for about 90% to 95% of all diagnosed cases of diabetes. It usually begins as insulin resistance, a disorder in which the cells do not use insulin properly. As the need for insulin rises, the pancreas gradually loses its ability to produce insulin. Type 2 diabetes is associated with older age, obesity, family history of diabetes, history of gestational diabetes, impaired glucose metabolism, physical inactivity, and race or ethnicity. Type 2 diabetes is increasingly being diagnosed in children and adolescents. In type 2 diabetes mellitus cases, insulin in circulation is low, normal, or even high. For people with type 2 diabetes, diet and exercise may be enough to control blood glucose level in some. When the diet and exercise is no longer efficient, oral hypoglycemic drug or insulin subcutaneous injection may be prescribed. So management of diabetes mellitus. The aim of management of diabetes mellitus are to control hyperglycemia, to minimize the risk of long-term microvascular and macrovascular complication. Treatment of diabetes mellitus include A. Dietary and lifestyle modification, B. Oral hypoglycemic drug, and C. Insulin therapy. Now, diet. Diet is a basic part of management in every case. Treatment cannot be effective unless adequate attention is given to ensuring appropriate nutrition. Dietary treatment should aim at ensuring weight control, providing nutritional requirement, allowing good glycemic control with blood glucose level as close to normal as possible, correcting any associated blood lipid abnormality. Exercise. Physical activity promotes weight reduction and improves insulin sensitivity, thus lowering blood glucose level. Together with dietary treatment, a program of regular physical activity and exercise should be considered for each person. Such a program must be tailored to the individual's health status and fitness. People should, however, be educated about the potential risk of hypoglycemia and how to avoid it. Now, insulin. When it is discovered, insulin was discovered in 1921 by Banting and Best. They demonstrated hypoglycemic action of insulin. Insulin was first obtained in pure crystalline form in 1926. Structure of insulin. Insulin is a two-chain polypeptide having 51 amino acids. A chain have 21 amino acids, B chain have 30 amino acids. The A and V chains are held together by two disulfide bonds. There are minor differences between human, pork, and beef insulin. Pork insulin is more homologous to human insulin than beef insulin. Synthesis. The islets constitute 1% by weight of pancreas, and there are about 2 million islets in the human pancreas. The islets contain three types of cell: alpha cell, which secrete glucagon; beta cell, which secrete insulin; and delta cell secrete somatostatin. Insulin is synthesized in the beta cell of pancreatic islet as a single chain peptide precursor called preproinsulin, which contains 110 amino acids, from which 24 amino acids are first removed to produce proinsulin. The connecting or C peptide 35 amino acid is split off by proteolysis in Golgi apparatus. Both insulin and C peptide are stored in granules within the cell. C peptide is secreted in blood along with insulin. This is the structure of insulin. A chain and B chain, which is bound together with disulfide bond. Regular regulation of insulin secretion. Insulin is primarily regulator of glucose metabolism and storage. Insulin is secreted from pancreatic beta cell into the portal circulation. Under basal condition, 1 unit insulin is secreted per hour by human pancreas. Much larger quantity is secreted after every meal. Pancreas secrete about 50 units of insulin in 24 hours. Secretion of insulin from beta cell is regulated by chemical, hormonal, and neural mechanism. There are three mechanisms of secretion of insulin. Chemical mechanism. The pancreatic beta cells have a glucose sensing mechanism depending on entry of glucose into the beta cell. Entry of glucose in the pancreatic beta cell is by facilitated diffusion due to concentration gradient through cell membrane glucose transporter GLUT. Glucose is then metabolized by glycolysis and oxidative phosphorylation. The first step of glycolytic pathway, the conversion of glucose to glucose 6-phosphate, which is catalyzed by the enzyme glucokinase. The activity of glucokinase varies markedly according to the concentration of glucose. This makes it a very effective sensor in the beta cell. Hormonal mechanism. A number of hormones stimulate insulin release in response to glucose, for example, growth hormone, corticosteroid, and thyroxine. Somatostatin inhibits release of both insulin and glucagon. Glucagon stimulates release of insulin and somatostatin. Insulin inhibits glucagon secretion. The three hormones released from closely situated cells influence each other's secretion and appear to provide fine tuning of their output in response to metabolic need. This shows hormone secretion within isolates. It shows somatostatin inhibits release of both insulin and glucagon. Glucagon stimulates release of insulin and somatostatin, and insulin inhibits glucagon secretion. Now, neural mechanism. The isolates are richly supplied by sympathetic and vagal nerve. Adrenergic alpha 2 receptor activation decreases insulin release by inhibiting beta cell adenyl cyclase predominant. Adrenergic beta 2 stimulation increases insulin release by stimulating beta cell adenylyl cyclase less prominent. Cholinergic muscarinic activation by acetylcholine or vagal stimulation causes insulin secretion. Action of insulin. The action of insulin and the result of its deficiency are as follows. First, insulin facilitates glucose transport across cell membrane, especially in skeletal muscle and adipose tissue. Insulin facilitates intracellular utilization of glucose by increased production of glucokinase, which is essential for phosphorylation of glucose to form glucose 6-phosphate. Insulin facilitates glycogen synthesis from glucose in liver, muscle, and fat by stimulating the enzyme glycogen synthase. Insulin also inhibits glycogen degrading enzyme phosphorylase, so decreased glycogenolysis in liver. Third, insulin inhibits gluconeogenesis in liver from protein, free fatty acid, and glycerol. In insulin deficiency, protein and amino acids are funneled from peripheral tissue to liver, where these substances are converted to carbohydrate and urea. Thus, in diabetes mellitus, there is underutilization and overproduction of glucose, leading to hyperglycemia and glycosuria. Insulin inhibits lipolysis in adipose tissue, and favors triglyceride synthesis. In diabetes mellitus, increased amount of fat is broken down due to unchecked action of lipolytic hormone. Glucagon, adrenaline, thyroxine. Increased free fatty acids and glycerol in blood taken up by liver to produce acyl coenzyme A. Normally, acyl coenzyme A is resynthesized to fatty acid and triglyceride, but this process is reduced in diabetes mellitus and acyl coenzyme A diverted to produce ketone bodies, acetone, acetoacetate, and beta hydroxybutyrate. The ketone bodies are released in blood and partly used by muscle and heart as energy source. But when their capacity is exceeded, ketonemia and ketonuria result. This picture shows how the normal blood glucose level maintained in normal individuals. When there is high blood glucose level, then beta cell release insulin into blood. And what insulin where insulin acts? First, in muscle and other cells use glucose as an energy source or convert it to glycogen and act on liver which converts glucose to glycogen, fats, and protein. Blood glucose level thus maintained, less insulin produced. Normal blood glucose level maintained, and when low blood glucose level, then pancreas release glucagon, which act on liver and liver converts glycose into glucose. So, blood glucose level rises, less glucagon produced. This is homeostasis. Insulin therapy, short term use, acute illness, surgery, stress, and emergency. In pregnancy, during breastfeeding, insulin may be used as initial therapy in type 2 diabetes in marked hyperglycemia. Severe metabolic decomposition, diabetic ketoacidosis, hyperosmolar non-ketonic coma, lactic acidosis, severe hypertriglyceridemia, and long-term use. If target have not been raised after optimal dose of combination oral therapy, consider change to multi-dose insulin therapy. When initiating this insulin, secretagogues should be stopped. What is secretagogues? Drugs which increase secretion of insulin. So, insulin secretagogue should be stopped and insulin sensitizer like metformin or thiazolidine can be continued. So, indication of insulin therapy. First, type 2 diabetes not controlled with maximal dose of oral hypoglycemic. Generally, oral hypoglycemic agents is sufficient for type 2 diabetes mellitus, but when it is not controlled with maximal dose of oral hypoglycemic agent, then insulin can be added. Type 2 diabetes during periods of physiological stress, surgery, infection. Continue oral hypoglycemic agent simultaneously. Stop metformin in case of severe infection or impending induction in renal perfusion. Third, pre-gestational diabetes. Metformin may be continued. Discontinued other oral hypoglycemic agent. Insulin may be added. In pre-gestational diabetes, that means diabetes prior to pregnancy. Gestational diabetes, when blood sugar level increase during pregnancy. Metformin or insulin. Use of parenteral nutrition or high caloric supplement. Diabetes ketoacidosis, hyperosmolar hyperglycemic non-ketotic syndrome, progressive complication, proliferative retinopathy, maculopathy, progressive or painful neuropathy. In this condition, insulin is indicated for rapid control and tighter adjustment. Classification of type 2 type of insulin. Classification or type of insulin. Human insulin and insulin analog are available for insulin replacement therapy. Insulins are classified according to timing of their action in the body, especially how quickly they start to act, when they have a maximal effect, and how long they act. Short acting or rapid acting, intermediate acting, long acting. There are three types of insulin: short acting or rapid acting, intermediate acting, and long acting. Therapeutically used human insulin are analog preparations prepared by recombinant technology. Human insulin are pure and stable, neutral in pH, and less likely to cause subcutaneous fat atrophy and less antigenic. So, generally, human insulin are used. And preparation: short acting or rapid acting, regular human insulin, and analog, that is lispro, aspart, and glutathione. Short acting In short acting or rapid acting, peak time is 1 to 2 hours and duration of action is regular human insulin 6 to 8 hours and analog, that is lispro, aspro, and glutathione, it is 4 to 6 hours. Intermediate acting, lenti-insulin zinc suspension. What is lenti-insulin zinc suspension? 16 to 20 hours. Peak time 4 to 10 hours. Intermediate acting, lenti, and NPH. NPH, neutral protamine Hesdor insulin. NPH insulin is neutral protamine Hesdor. Duration of action 12 hours. Long acting, no peak. Glargine or Lantus, 24-hour duration of action. Determine 16 to 24 hours. Biphasic premixed, mixed start. Yeah, that means regular plus NPH. That means short acting and intermediate acting. Premature mixed start, regular plus NPH. It comes in three forms: 30-70, 25-75, and 50-50, in which percentage of this percentage of regular and NPH insulin. Duration of action biphasic 24 hours. Pre-mixed insulin, pre-mixed 30-70, that means regular 30%, NPH 70%, pre-mixed 50-50, regular 50%, NPH 50%, pre-mixed analog biphasic insulin aspart 30-70, 30% aspart and 70% protaminated aspart. Pre-mixed insulin dose adjustment. The fasting sugar depends on the night dose of insulin. The post-breakfast sugar depends on morning dose of insulin. A rough calculation increase the insulin by 1 unit to reduce the sugar by 25 milligram per deciliter. Usually, a starting dose zero point 0.5 to 1 unit per kg per day. Route of administration of insulin. Insulin is usually given subcutaneous either by injection or insulin pump. In acute condition, insulin may be given intravenously. Pre-mixed insulin advantage: more accurate dosing, lesser injection, pen device administered premixed form. Disadvantage: fine tuning may not be possible. A strict meal pattern, nocturnal hypoglycemia may need diet changes for insulin rather than insulin changes for diet. And next, oral hypoglycemia in separate class.